You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today's episode is going to be focused on suicide prevention on the front line. So every year, thousands of lives are lost to suicide, and frontline staff are often the first to support during these critical moments. So in the episode, we're going to explore the vital role that London Ambulance Service plays in suicide prevention and risk assessment. So from the moment a call comes into the control room to the interaction on the front line, paramedics and indeed pre-hospital staff are trained to recognise the signs of suicidal ideation and indeed act quickly to prevent harm. So in the episode, what we're going to do is dive into the clinical and operational aspects of suicide risk management. We're going to discuss how paramedics assess risk and indeed work alongside other services like the police, mental health crisis teams and hospitals to ensure best possible care. So you're going to hear about the collaborative efforts that help create some of the seamless response to those in the most need of help and indeed in vulnerable states, and the challenges involved in coordinating care across various agencies. So in this episode, we're going to look at, and it really does offer a candid review into the realities of suicide prevention in pre-hospital care and the steps that can be taken to save lives. So I'm joined by Carly Lynch and Dan Phillips, who joined me on the first episode. Welcome both to the podcast.
Thank you for having us.
It's great to have you both with us again, actually. I just wondered if we could just kick off, and Carly, I'll come to yourself first, and really just maybe get you to speak to some of the key warning signs that paramedics and indeed control room staff look for when assessing suicide risk.
Thank you. Yeah, that's a big question, and I think I'd like to start off by saying that, suicide is a really complex thing, and if we lose a patient or a relative or someone we know to suicide, the impact on the person and the people left behind is devastating. And it's something that over the years I have lost kind of patients to suicide, and it never really kind of leaves you, and a lot of questions kind of play over in your mind. Did I miss something? Did I do something wrong? And the people who have worked with the patient can feel a lot of guilt and complex emotions, as it's such a complex thing that we don't kind of fully understand as such. Risk assessment, we have some kind of risk assessment frameworks and things that we kind of look out for, but ultimately sometimes suicide is quite unpredictable. And there have been some kind of papers published where people have spoken to kind of suicide survivors, and there is some evidence to indicate that although the person may have been struggling for quite some time with their mental health or with life struggles in general, the actual decision to act on the thoughts can be quite impulsive towards the end. So yeah, it is really complex. But in terms of how we manage it in the pre-hospital setting, I think the first thing we encourage staff to do is to actually ask the question. And if somebody is disclosing that they're kind of having some mental health difficulties, or they're struggling with some social difficulties, it's a really good tip to say, given all the things that you're dealing with at the moment, have you ever felt that life isn't worth living? And then to normalize that and say that can happen quite a lot for people who have had similar experiences to you. And by kind of opening up that discussion, it does give the opportunity for the person to maybe speak about how they're feeling. And we know that actually that can help, to get people to disclose how they may be feeling, because they may have been bottling up things for a long time. And I think historically there's been kind of, people and staff might feel quite anxious about asking the question, but actually we know that by giving that person time and space to talk about their difficulties, may help for them to share things with us, and we can help to support them kind of going forward. it's a mixed bag. Sometimes people will be very explicit in how they're feeling and be very open, and then sometimes people will be quite secretive and they'll tell us, no, I'm fine, kind of go away type situation. And for me as a clinician, the group of patients who are kind of pushing me away, saying, no, I'm fine, I didn't call for help, I don't need help, they're patients that I would really be extra concerned about. And we know that there is some kind of phenomenon that people who are in a pre-suicidal state of mind can experience, where they will be pushing people away and kind of alienating themselves. So that can be a risk factor. We also know that kind of past history can be a huge indicator. Obviously, if people have made kind of serious attempts in the past, then that's also a kind of risk factor. And then on the converse to that, if there is no known history, and if people aren't under mental health services, we also know that that can also be a risk factor for suicide. So it's really key, and we encourage our staff to call the local mental health services to get some history if the patient isn't forthcoming or they're not able to establish the kind of baseline presentation for the patient. So they're things that our staff are kind of trained to do. We obviously also have static factors. So there's kind of prevalent studies in kind of people who have had their deaths recorded as suicide. We know that obviously being a middle-aged male is an increased risk of dying by suicide. We also know that kind of being quite isolated and having not a big support network can also be a risk factor as well. Things such as kind of stressful life events. So if there's been a relationship breakdown, or there's been a significant change in that person's kind of status, it could be a job loss or kind of economic concerns, that can also be a risk factor. And there's a really good book that I would recommend to your listeners called Working in the Dark, Understanding the Pre-Suicidal State of Mind. And the authors of that book talk a lot about patients who have died by suicide. They may have had significant loss in their life and not been able to mourn that loss. So it could be a bereavement, but it could also be, as I mentioned, relationship breakdown. So that's really key as well, if the person kind of hasn't been able to process some of the difficulties that they're facing. We also know, as I mentioned at the beginning of this question, if you have lost somebody close to you by suicide, that does increase your risk of yourself going on to kind of attempt or complete suicide. So that is also a risk factor. And then also there are some kind of personality factors and traits that can play a part in people, being an increased risk of suicide. So if people are quite impulsive, if people get quite kind of fixated and anxious about things, and that can also be kind of a risk factor as well. And then obviously we have things such as chronic physical health conditions. So if people are living with a lot of pain, for example, that can also impact on their mood and their mental health and increase their risk of suicide, as can kind of use of drug and alcohol. And I think obviously the drug and alcohol can be incredibly risky for us as clinicians in the pre-hospital environment, because if we meet somebody who's intoxicated, we know their level of impulsivity is likely to be higher if they're under the influence, and they may kind of make decisions that they might not do when they're sober. And then also people who are involved in the criminal justice system. So we know that the kind of prison population as well is at an increased risk. So how do we get into the nuts and bolts of this? We have we're very clear that we don't use kind of ranked or scored kind of risk assessment tools to assess kind of suicide risk. So we would do our mental state examination on the patient, kind of look at how they're engaging with us. Are they kind of withdrawn? As I said, are they kind of pushing us away? Is it difficult to build a rapport with them? You know, how do they feel about the future? We'll be asking them, you know, how do you see things? And if people can't see a future or things improving, again, that would be a risk factor. And then we would form our risk assessment. We're just about to launch a new assessment framework within our electronic patient care record, which encourages our staff to kind of consider all of the risks, so the risk to self, risk to others, and risk from others. And it's about kind of, you know, thinking through with the patient what all of these risks are and how we can mitigate them. So it's literally a case of writing the risk down instead of kind of ranking it, you know, low, medium, or high. And then obviously we would look at what we would call the protective factors. So, you know, what's important to the patient, what gives them some hope, because where there's some hope, that would be seen as a positive sign. And then obviously all of our staff are encouraged to kind of have some joint decision making. So that's where we encourage staff, and they're trained to call the local mental health single point of access, involve the patient obviously in the risk assessment, but also the kind of loved ones, and then make a kind of plan about what needs to happen. And then obviously a safety plan as well. So if things deteriorate when we leave, you know, what steps do you need to do? Who do you need to call? What are your warning signs? So yeah, it is complex, and you know, but we know that by kind of talking, and referring people to the right place, that can give people hope to get that they will get better. And absolutely, kind of people, you know, can recover and do recover when they're experiencing these kind of thoughts and experiences.
Yeah, absolutely. As you said, Carly, it is complex and it's multifactorial in both risk, but also in some of the prescient factors which of causation. And as you said, it's prudent to really look at a wider gamut of the social influences and indeed the support networks. But something critical you said there absolutely is getting an accurate history. And if that can't be conveyed from the patient, maybe a mental health team that do know the patient, just to get that accurate history. Dan, I'll come to you, and just something you said in the last episode, which is really relevant, which is there is a bilateral assessment of a patient, which is a physical patient, a physical assessment and a mental health assessment. Could I get you to speak to that interplay? Do you normally preference the physical assessment first and foremost? I think why you're absolutely right in this is sometimes the physical assessment can actually lead and start to reveal some of the psychological subtle ones, and you know, classic case, you know, blood sugar, you know, there is an altered mental status, but also some subtle signs, which is, like you said, you know, tablet compliance. If they've not been compliant to their antidepressant medication, you know, and actually you're digging into some of these subtle signs and assessment signs which actually might lead to the psychiatric. Could I get you to speak to that interplay?
Yeah, absolutely. And thanks. Yeah, it's a really important question. So we know that the physical health needs of this patient group, you know, are often going unmet. So, for example, people with a severe mental health illness, we know are often have life expectancies of up to 20 years less than the general population, and that 2 and 3 of those, the deaths that affect people with severe mental illness, are due to preventable physical health issues. Which I think is a really, you know, sad statistics that all, you know, should give all clinicians pause for thought. And actually, parity esteem, or the concept of giving equal priority to both the mental and physical health need of the patient, was actually enshrined in law in this country in the Health and Social Care Act back in 2012. So yeah, sort of as you say, it's really important that we're sort of assessing both and giving sort of both equal importance, sort of as we consider the patient and their needs. So in terms of balancing the two aspects of care, sort of as you just actually alluded to, initially it can sort of from a non-mental health professional point of view, going into scene and sort of starting your patient assessment, it can help sort of everyone on scene sort of feel a bit more at ease, a bit more comfortable, both, you know, clinician and patient, to go in and sort of start sort of commencing with the physical health assessment. I guess for somebody in distress, something as simple as going in, you're doing your sort of your standard primary survey, and something as simple as taking someone's pulse, and that sort of human connection can sort of can really change the dynamic, and really hope and maybe make things a bit easier for people to speak, and hopefully lead to people opening up. That said, obviously, critical physical health illness takes priority on scene, obviously. If upon arrival, we found that somebody's has already sadly, overdosed, or there's some significant deliberate self-harm. Likewise, if there's an obvious underlying cause for the mental health presentation, there's like an obvious infection or sort of meeting sepsis criteria, then absolutely that needs to be dealt with first and foremost, prior to anything else. However, yeah, once sort of those more acute presentations are ruled out, then we can absolutely move on to assessing the mental health and physical health sort of more concurrently. I think one of the things that I found most eye-opening, again, sort of working on a mental health team within an ambulance service, has been actually the frequency that we as healthcare professionals, when meeting this patient group, are actually really able to uncover underlying physical health issues that are often going under the radar, be that because the patient is not engaging because of their illness, or other reasons, sort of to do with health inequalities and issues of access to healthcare. So often these issues don't necessarily require going to the emergency department based on the presentation, but very frequently what we're doing is referring both to a mental health and a physical health service for the same patient. And yeah, I think the ambulance service is just in a really privileged position where we're meeting people who often aren't able to access parts of the healthcare system for one reason and of another. And sort of, as I just alluded to in relation to health inequalities, being in a very privileged position, even just within healthcare, we really need to be getting it right and addressing all their needs and making sure bits aren't slipping through the net. And then I think just the last sort of point, just that I'll come to, and then obviously if there's anything you think I've missed, please pull me up on it, is obviously just when considering assessing both mental and physical health together, obviously just the risk of diagnostic overshadowing, and attributing a physical health complaint from the patient as a mental health issue. We need to adequately investigate and scrutinize anything that the patient's telling us, and sort of ruling out underlying causes to ensure that something significant doesn't slip through the net, that could lead to sort of the patient coming to harm down the line or deterioration in their condition. So ensuring that all these patients are we're undertaking observations and standard physical health assessment. And then it's just really important that we're not making assumptions. We need to be if it is if we do think that a symptom is possibly more related to like a psychological issue, then we need to be confirming that with mental health services. And again, if it's not known, that in itself is relevant and would warrant further follow-up, either with the GP or at hospital, depending on the acuity. And yeah, so I think assessing both is complex. And I think, again, it's why I think we see the beauty of the model of putting a paramedic with a mental health nurse out together has been so game-changing for the patient group. And I think why we feel strongly that the pre-hospital setting needs more collaborative working between these professional groups and not less of it.
Yeah, absolutely. I couldn't agree more, actually, Dan. And something you said there, which is absolutely key, is, like you said, it's a real privilege to see patients in their own environment, because as Carly can probably attest to in various other clinical settings, you don't see in hospital, you don't see the social setting, you don't see maybe the lack of self-care, the social living conditions, and everything which can maybe even instruct you and help you as to where the sort of psychological and physical state is of the patient. So absolutely, there are subtle key signs that can also really unpack the current condition. Something which I'll come to yourself, Carly, about is something that I struggled with certainly as a advanced paramedic practitioner, but absolutely as a paramedic and otherwise, was actually when the patient wasn't in their own home, when they were in a public place, and there was an acute onset of a psychiatric condition. These characteristically occur in transport hubs or indeed on bridges or otherwise, and knowing trying to relate to patients in a way to try and verbally de-escalate the situation and bring them to a sense of, because to your point, you don't know their baseline, you maybe have no prior rapport, you don't necessarily have the social indicators to instruct you because you're not in the patient's home. Carly, could I get you to speak to just maybe some of the verbal de-escalation tips that you've carried into the ambulance service and indeed inform some of your colleagues with, just to really, in a way, de-escalate situations, bring patients back to hopefully some kind of baseline and sort of build quick rapport?
Yeah, I think that was a big thing for me as well, the difference, because previously I'd kind of worked in A&E or on wards or with kind of patients, in the community in their own home. So yeah, often in these situations, as you said, we might not even know who the person is. Like sometimes we might not even have a name in those situations. And by virtue of the fact it's in a public place, there might be a lot of kind of members of the public around, kind of, looking at what's going on and what's unfolding. So, yeah, I think it's really key to be able to find the person on. It's a complete kind of multi-agency response, and often here we will have kind of the police on scene, potentially, the fire brigade if it's, somebody at a height, and maybe a couple of ambulance responses as well. So it's really key that we find the person who can build that rapport with that person, and so it's about kind of who's the right person to try to engage with that patient, and it could be that if say for example I'm working with Dan, it could be if it's a male of a similar age to Dan, he might be better at getting the rapport with that person than I can. So it's about kind of looking to see who can have that rapport with the patient. Obviously, we need to make the person, it's about also containing our own emotions as responders, because we will be feeling kind of very anxious. Obviously, we don't want anybody to come to harm. We need to maintain our own kind of safety, and there'll be a lot of people on scene as well who may be supporting to manage the actual scene for us, and it can be quite noisy. So it's really important to look internally at how we're kind of coming across. And although we may be feeling very anxious and worried ourselves about what might happen, it's about not letting that show to the person, because ultimately we need to make that person feel what we would call in mental health contained, that we are here and that we want to support them, and to give that kind of hope. So yeah, we have to be really mindful about the tone of our voice. I think sometimes people may be kind of shouting get down, and that can overstimulate the person. Appreciating if it's in a very busy place, you may have to talk in a slightly kind of raised voice, but be mindful about the tone of your voice, and obviously if the patient can see you, your body language. So you don't want to be, you want to look like you're really engaged with the person, so kind of an open posture, and to make sure that we're listening, and to be maybe reflecting back to the patient when they're responding to us, so they know that we are listening and kind of hearing what they're saying, and then it's about kind of having that conversation, and ultimately what this is kind of two humans having a conversation, and one of the humans, that the responder, is trying to give some hope for that person and letting them know that things can get better and can change for them. So yeah, it could be that you manage to get a tiny bit of information about the patient, things that maybe are important to them. It could be, I don't know, family member or a pet or a hobby that they've enjoyed at some point, and then maybe get them to kind of, talk about that, just to make them, because they themselves will be feeling very anxious and scared and very desperate as well. So yeah, it's a complex situation, and obviously if we do know the person, then colleagues in the background can be maybe getting some kind of information. We do also have negotiators that are trained, that they work for our kind of police force here. So they may also come to scene, but it depends on kind of availability, and yeah, so that they may also kind of come to kind of help. So I think when you have somebody in that situation, um, that they're there, if the person's say on a bridge and they haven't jumped, that's a kind of reachable moment. We would view it as that we can talk to that person and try to contain them, as much as possible. And then obviously once we have, hopefully got that person to safety, then there's a discussion around kind of what needs to happen kind of next for that person. It could be usually maybe going to hospital because the kind of risk has increased significantly, and then there may be some kind of pieces of legislation used here. So it could be that the person is detained, and under a section of our mental health law here, and we may assess the person's kind of mental capacity to make decisions as well. So yeah, it is kind of complex. Yeah.
Yeah, indeed. No, indeed. Dan, on the last episode, you really spoke to, the improving aspects of care amongst MDTs, multidisciplinary teams, not only with, like you said, the mental health nurse and the paramedic on a car, which is a fantastic MDT asset and resource which attends patients, but the hospital working and the ways in which you hand patients over, just in the way the checklists and indeed the handover procedure. But could I get you to speak to bring it right back to point of call, actually, Dan, and could I get you to speak to really the role of the emergency operations centre in the play in triaging these patients and indeed dispatching the right resource for suicide-related calls, dispatching maybe a mental health nurse and indeed a paramedic. Could I get you to speak to how these calls are flagged and then maybe even indeed sent to someone like yourself on a car?
Yeah, absolutely. So obviously initially call comes into the service, following an initial triage with one of the with one of the 999 call takers, the call will receive an appropriate category. Following on from that, obviously it will go into a queue relevant to that category code, which we have C1 for the most life-threatening emergencies, for sort of through to C2, 3, 4, 5. We then have various different clinicians and staff members who will be scouring those queues, and looking to ensure that, obviously still the principles of triage, the most unwell patients get the ambulances first. And then they're also scanning those queues to look for patients who sort of may benefit from either a specialist response or hear and treat, or who are possibly suitable for hear and treat, and having the call resolved over the phone. So if a call is identified as possibly mental health related, they will then be filtered into a separate screen, where in the control room, one of the mental health nurses or one of the mental health professionals working in the control room, or a paramedic who may be working it if there isn't a mental health practitioner on, they will be able to work through that queue and again sort of prioritize what needs dispatch. They're able to obviously ring the patients back, and they'll be doing work to liaise both with the patient, third-party callers, and crisis services to see what can be resolved, get some background history, and then also if it can't be resolved over the phones. I think in the last episode we talked briefly about the complexities of telephone assessment for a mental health call. They can then also they'll make sort of a final decision on what an appropriate dispatch would be. So some will be left in the queue for an appropriate ambulance response, if not upgraded for a higher time response, if there's like a more urgent need. And then they also have an ability to apply a flag that sort of tells the dispatcher that actually this would be a call that's appropriate for the mental health car to come and respond. And then that's how sort of our team would sort of end up being sent. There's obviously other factors at play. So we also have calls that come in directly from the Met, and then the dispatchers will sort of our dispatcher and their dispatcher will liaise and discuss the need for that call and whether that warrants sort of both organisations responding or just one or the other.
So Carly, just to yourself, could I just get you to speak to really some of the alternative care pathways to avoid unnecessary A&E admission, but also the adage of having a mental health specialist with a paramedic on scene to really expedite that and indeed facilitate that alternative care pathway?
Yeah, thanks. That's a great question. So I think within the mental health care team, from 2020 up until now, we've had, I think it's around 33,000 patient contacts, and our kind of conveyance to the emergency department rate is around 15%, and it's been quite kind of stable. Obviously it slightly fluctuates, but it's within kind of normal parameters. So I think it's really important to say that we have a pretty large evidence base now to show that actually not conveying people to A&E, and I should have also said when I said that to date we haven't had any kind of serious incidents that have occurred through kind of leaving a patient at home. So I think we have this large evidence base that shows our clinicians across the organisation that actually there are a lot of times where we can leave our patients at home with appropriate follow-up. So I think a key here, and the reason why the mental health cars, are, for want of a better word, so successful, is around the ability for the mental health clinician on board the crew to have that negotiation with the mental health trust. And it's almost, like you're talking a similar kind of language, and there's an understanding of the kind of risk tolerance. So it's really key to have that kind of negotiation, and sometimes potentially there may have to be a more robust conversation with the mental health provider to say, absolutely, we don't feel this patient needs to go to A&E and we would like you to follow up your patient. So we have various kind of routes, as you said, they're called kind of alternative care pathways that are kind of agreed, and they have some kind of governance around them, pathways between us and the mental health provider. So obviously the first one that we've kind of talked about a little bit during this episode is the kind of single point of access or crisis line, and they're really great for getting the collateral information on the patient, what's the plan for the patient, and then that also kind of helps with our risk assessment as well. And then there is slight variation, but often the single point of access can arrange some follow-up for the person with their mental health team or with a crisis team. So that's really kind of our main bread and butter, shall we say. We also have the ability to convey patients to the mental health clinical assessment services. We have a few in the city, and they're kind of, I guess, as I said before, like a mental health kind of A&E department, where they're a standalone unit usually, and they'll deal with kind of mental health presentations. And then we also have crisis cafes, which tend to be run by kind of charity or third sector organisations, where patients can go. Usually it's out of hours and at weekends, to have some kind of, social contact and some peer support, which is really valuable, and we know kind of helps patients as well. So it's all about the kind of assessment here, and having a kind of assessment and risk assessment, and then then we can negotiate and see where the patient needs to go. But also, I do want to say that, there are times absolutely where our patient group do need to go to the emergency department, and, they have a right to go to the emergency department. And yeah, absolutely, there are times where it is the best and safest place for that individual. So, yeah.
No, indeed. So just pivoting for a second, Dan, if I could just come to you and just ask really just around a case study, really, where if you could just maybe illustrate a case where the London Ambulance Services, through the mental health response with a specialist and indeed a paramedic, has made a real difference in preventing suicide.
Yeah, absolutely. Thank you very much. So actually, yeah, interestingly, there's a case that Carly and I were recently reviewing for an acutely suicidal patient who on scene wanted to be left alone to end their life, and they were quite adamant that they wanted the LAS to leave. The crew on scene who were dealing initially actually escalated to the mental health car, and actually fortunately Carly was one of the crew who were in attendance to scene, and I think it's a really interesting case that shows an underlying physical health issue and a mental health crisis presentation. It's a pretty complex incident involving multiple considerations for the Mental Capacity Act. I'll obviously hand over to Carly in a second to give like a full rundown of the incident, as she'll do it far better justice than I could, as she was the one there. But yeah, the reason I think it's a really important case to share is I think ambulance-based clinicians were regularly in situations where we're being asked to make decisions for patients and balancing risks, and often considering the Mental Capacity Act and other legislation, often feeling quite isolated in making those decisions, and they can be really challenging situations, and it's no wonder that staff do find them such challenging situations. And actually, I think what's interesting about this case is it's very rare that we get an update on the outcome, which is, I think, what's different with this one. And it's interesting to find out how things end up. So with that, I'll pass over to Carly.
Thanks, Dan. Yeah, so this was a patient, as Dan has said, with kind of complex kind of physical and mental health needs, that they needed some kind of treatment for their physical health, and otherwise there was a serious chance that they would die if they didn't have that treatment. And then on the back of that, their mental health condition had also started to relapse, and then they'd gone to their hospital with a view to have this treatment, and then had been declining the treatment. The hospital were kind of deciding, what to do, what needed to happen next, and then the patient kind of left the hospital and went back home to their home address. And when they called on the phone, the patient was just saying, "Leave me alone, I just want to die." So yeah, it was a really kind of complex situation for the crew initially to manage, as the patient was just shouting from behind the door, like, leave me alone, leave me to die. And then myself and my colleague kind of went along to support the crew that were already on scene. And then it turned out to be quite a protracted incident, and in the end we had to gain entry into the patient's kind of property, and the patient was really unhappy, telling us to go, looked quite physically unwell, but then also mentally unwell, and was quite symptomatic with their mental health symptoms. Eventually they did end up coming with us to hospital, and it was felt that they kind of lacked capacity to consent to come to hospital with us, and whilst all of this was going on, we were in touch with the treating hospital, who had arranged a kind of bed for the person to come straight in to have the treatment that they needed. So it was a real kind of good example of everybody kind of working together. The patient was, at that time really angry, just saying leave me to die, and was quite kind of rejecting of help, and not happy that we were in their flat. And I also spoke to a family member who was slightly kind of ambivalent about what needed to happen. I think didn't want to kind of upset the patient and make the patient kind of, more stressed than they already were. And I think, obviously in the end, the outcome was the right thing for our patient. They went to the hospital that they needed to go to have the treatment that they needed. And yeah, but there was a clear sense that the patient was really quite frustrated and angry and not happy at our presence. And so I kind of went home that evening feeling, slightly deflated. Although I knew the right thing had been done, I was, it's not nice to know that the patient was kind of so kind of angry. And then it kind of like came into my mind a few times, in the next week or so. And then a colleague that I work closely with in this particular hospital, who actually kind of called me to say that the patient had been doing well, had the treatment that they needed and some treatment for their mental health, and wanted to pass on their thanks. They remembered kind of what had happened on that evening, and to say thank you, and it saved my life, and they wanted me to know that they feel a lot better now, and they're really glad that I made that decision for them, because they're feeling much better. So for me, that was just really powerful, because they we got to hear what had happened, but also it was a really good example of how probably physically they were feeling really awful, and then their mental state was relapsing, and just the fact that they felt so much better kind of mentally and physically, and also kind of remembered what had happened that evening. So yeah, I think that was a really good example of what when things work well and we work together as a system, and the positivity and good outcomes that come from that. So yeah.
Yeah,
Yeah.
absolutely. Absolutely. And I think, like you said, it gives credence to the MDT approach, the multidisciplinary team approach, and all coming together and for the patient and advocating for the patient. Just a couple more questions before we come into lands, really. One would be around just and I'll come to yourself, Dan, if that's okay, just around the service which you guys provide, and fundamentally is embedded within the ambulance service, which I think is a fantastic standard, and would love to see it be a standard of care across ambulance services, really, which is, providing training, providing co-responding, but also providing feedback through electronic patient report forms, and also training and debrief. Could I get you to speak to that? Because there is TRIM assessments that, because there is an emotional toll that these, as Carly was saying, that actually responding to these patients, you can be worried, or did I say the right thing? Did I do the right thing? Dan, could I get you to speak to really just in a way, the support that you guys give to frontline staff to really help them, and the burden of kind of attending some of these calls?
Yeah. And it's a fundamental question when it comes to responding, particularly to mental health. As obviously, in pre-hospital care, we're exposed to so much trauma and just difficult situations. But certainly working within a mental health setting, and we know that ambulance crews about 10% of the ambulance workload is mental health response. It's emotionally heavy work, and we do, like sponges, absorb through a process called transference. We do absorb a lot of the emotion, and just by the nature of being humans, and healthcare professionals being empathic, we absorb a lot of what we're dealing with. We also know that that suicide rates are on the increase. In 2023, there were 5,656 registered suicides in England, and that was up nearly 400 from the year prior. So yeah, so this is something we're seeing more and more of. So yeah, I think first and foremost, talking is key. It's really important to acknowledge emotions and talk about these difficult jobs. And I think that's definitely something we don't do enough of. I think because we do go to a lot of these mental health calls as an ambulance service, that it's sort of treated as just normal and just like, part of the job. But actually, we should be talking about it more because, and not be playing down how much of that our crews are absorbing. Something that we sort of try and offer to our team and would love to, and I know that bits go on throughout the service that we try and support with this as well, is a sort of case-based discussion, and then sort of allowing sort of crews to bring particularly difficult or jobs that are stuck in their mind for one reason or another. And then sort of to sort of debrief, talk it through, and sort of try and tease out why, sort of what part of the job is it that's sort of sticking with them, and is it something that they did and could have done differently? Is there learning here, or actually is this sort of just a nature of working, in mental health or in a service where you're sort of exposed to like sort of more traumatic events, as I previously mentioned. So yeah, so we'll sort of try and get sort of deep into that and try and sort of unpick that for the clinician. Likewise, the importance of supervision and regular sort of touch points, with the staff member and their line manager, and as well as group supervision, is completely invaluable to make sure that people sort of have that opportunity to sort of talk about the bits that are bothering them, or something that again is playing on their mind. And again, for particularly complex jobs, or if particularly something particularly traumatic has happened, again, the importance of making sure people are referred for like trim assessments, to make sure again that people are getting what they need, and that staff are accessing support services that their own trust are offering. We try and offer training, we do offer training, and I think the key is really just sort of talking and sharing when things are a problem, and sort of looking out for your crewmate and those standard things. I guess and it sounds like a cliche, but enough can't be said for the old cup of tea in the mess room, and sort of asking a colleague how they're doing, and sort of that sort of approach. Yeah.
And just I absolutely agree with that, actually, and actually offloading the mental filing cabinet. And as you said, Dan, this the concept of transference is absolutely real, where the constant exposure to social deprivation and the psychiatric and psychological impacts of attending high acuity, or indeed even low acuity, but the aggregation over time is absolutely key. It's good to acknowledge that, absolutely. Just as we finish off, Carly, just the final question, if possible. You have already spoken to the fact there is some pre-hospital suicide prevention strategies in place, and there's also a review going on with the risk assessment tools, and indeed just the way that we safety net these patients. Could I just get you to finally speak to really the changes and improvements that you'd like to see in this space? Because I think, as you said before at the start of this conversation, it's extremely nuanced. It's fraught with risk, fraught with details, and indeed risks that we don't necessarily just see on scene. But could I get you to speak to some fundamental changes and or improvements which are underway, and that staff should engage with?
Yeah, that's a great question. So I think I mentioned it in the first episode. It really has to start before things get to a crisis point. That in an ideal world, that we should see very small numbers of people getting to the point where they feel that they need to call 999 for their mental health, or crisis, or depending, whatever's happening for them. But as we know, our kind of call volume is growing and continues to grow. So I also think that it's important, and I think I've been in the ambulance service now for 10 years, and I think there's definitely been a change, but the ambulance service, or services need to really be seen at a front and centre of suicide prevention, actually. Given the sheer volumes of calls and patients that we see for their mental health difficulties, ambulance services should be seen as a major provider of mental health kind of crisis care. So it's about having a seat at the table around suicide prevention strategies. And there has been a lot of work in London, led by the kind of Mayor's Office and NHS England around suicide prevention. So, looking at kind of population-based prevention. And the ambulance service in London is definitely now, I think, seen as a more key player. It's also, about improving inequalities, obviously kind of health inequalities, but looking at the social kind of factors that can affect people's mental health and feel that they don't want to kind of live anymore. So yeah, that is also something that I think needs to be looked at as a society. And obviously since COVID, there does feel like there's a growing divide as well, and people are feeling more desperate, I think, at times, and struggling with day-to-day life and the economy and things such as that. It also starts in our childhood, our early attachment, and how we experience our childhood and the world, and education. So I think kind of, having things available in schools is also key to prevent people, becoming, really mentally unwell when they're adults. And we know actually that most mental health conditions do start in the kind of teenage time. So that's something I think that we need to do to kind of look at prevention. And there is our CAMS colleagues are working very hard, and the waiting lists are going up as well. So yeah, and I also think it's about our staff as well, because as we've said, that the nature of the work in the emergency services it's difficult, and you see things that maybe your friends who work in banks or in offices wouldn't really begin to understand what our responders kind of see, and the having to contain situations. Yeah, so I also think that it's around kind of supporting our staff's mental health is also kind of key. Yeah, they're the main things really that I think we are focusing on, and we should definitely focus on as both a kind of organisation but also as a society as well.
Listen, that's fantastic. That's fantastic. And like you said, it's systemic, there's societal and service, and indeed individual responsibilities that we can engage with. But absolutely, it's holistic. Absolutely. Listen, thank you to you both. It's great to have you on the previous and indeed this episode. We'll be seeing you again shortly for the final episode of Mental Health. We'll dive into a few pathology based questions in the next episode. But it's just great to get both of your perspectives. Thank you, Dan and Carly.
Thank you very much.
Thank you. Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.